انفكشن يعني قال قصدك
احنا على الجدول المعمول بينه قبل نص السنه المفروض البون انفكشن يعني تكون من ضمن المحاضرات اللي تاخذوها الاسبوع الجاي ان شاء الله.
نعم.
نرجع عشان العماده بالموضوع، احتمال نكمل المحاضرات او نتوقف نشوف امتحانات نص السنه امتى راح تكون حددوا لكم موعد؟
حسب التقويم مال الوزارة 18/3.
18/3
نعم.
يعني امتحانات 18/3 اذا عندنا مجال بعد نرجع عشان ان شاء الله
إن شاء الله.
بالنسبه لنا المحاضره اليوم عن fractures and trauma of the hand، وهي تشعبة طويلة متشعبة بها مواضيع مهمة كلش very important، وبها يعني شغلات just to know. اوكي، فبعض الامور كلش مهمة ان تعرفوها مثل الكوليز فراكتشر اللي راح نجي نتكلم عليها، مثل فراكتشر سكافويد، اليونت ديسلوكيشن. زين راح نبدا اليوم ان شاء الله بالمحاضرة. بسم الله الرحمن الرحيم. First of all, we will discuss the fracture of the distal radius and what can happen, what we can face in the distal radius. First of all, very important, a fracture, and daily we see it in the emergency department, what we call Colles fracture. This fracture is described by Abraham Colles in 1814. Very important is to know the definition of Colles fracture. It is a transverse fracture of the distal end of radius with the posterior displacement of the distal fragment. It is most common of all fracture in the human being, mainly in old osteoporotic people, but it occurs in all age group. The main mechanism of this injury is a fall on outstretched hand. As you see in this picture, any patient fall on outstretched hand, especially in those osteoporotic people, the patient may develop a transverse fracture in the distal part of radius. If there is displacement of this distal piece dorsally, it is called Colles fracture. Sometimes in Colles fracture, in old osteoporotic people, we can see comminuted distal end of radius. Very important things is this fracture not extend to the articular surface. So the Colles fracture and the other reverse Colles fracture from Smith fracture is the fracture above the joint. It is in the distal edge of the radius. So again, it is usually transverse fracture. Sometimes we see a comminuted distal end of radius with the dorsal displacement in relation to the normal anatomy of the body. Clinically, the patient presented with sign and symptom of a fracture like pain, local tenderness, and loss of function of the wrist and hand. In displaced fracture, the deformity called dinner fork deformity. Sometimes we see undisplaced fracture of the distal part of radius. So in displaced fracture, the dinner fork deformity is very obvious. X-ray very important is to prove the diagnosis and to start the treatment after that. In X-ray, we see a transverse fracture of the distal radius at the corticocancellous junction, and the distal fragment again displaced posteriorly. As I said, sometimes we can face severely comminuted or crushed fracture of the distal end. As you see in this picture, it is a transverse fracture. Sorry, there is a swelling and a deformity of the distal radius. It is called dinner fork deformity. Very clear picture. We can see the dinner fork deformity with the swelling of the distal part of the wrist joint. This is another picture of a transverse fracture in the distal part of the radius with the dorsal displacement of the distal piece. So it is called Colles fracture. Again, In AP view, we cannot judge whether it is Colles or Smith, so we depend on the lateral view to decide that this fracture is Colles fracture. Treatment for Colles fracture. In displaced fracture, it must be reduced under general anesthesia. The reduction will be by traction on the hand in the length of the bone. The distal fragment then pushed into the place by pressing on the dorsum, while the manipulation of the wrist into flexion and ulnar deviation and pronation. And we keep this position. We apply after that a bag slab for immobilization and holding the fracture in flexion and ulnar deviation. Mild deflection about 15 degrees and direction for ulnar deviation also 15 degrees. Then we check the X-ray to check the reduction. In unreduced fracture, we need open reduction and internal fixation. Usually we apply the bag slab from below elbow to the neck of the metacarpals. We can change the bag slab to full POP after 7 to 10 days after the swelling subside and the hematoma decrease. So we change the bag slab to full cast POP for about 6 weeks. This picture demonstrates how the length of the cast is, and after application of good amount of cotton to protect the skin and the bony prominence, we apply the bag slab in this shape. Usually, we use the bag slab below elbow. And after 7 days, we can change it to a full cast POP or fiberglass splint. Complications of Colles fracture. We have an early complications and late complications. Early complication, circulatory problem. The circulation of the finger should be checked. The tight bandaging holding the slab need to be split. Sometimes we face nerve injury. Direct injury is very rare, but compression of median nerve in the carpal tunnel is common, and it is also late complication. Reflex sympathetic dystrophy, whether it is localized symptomatic overactivity, as we discussed it in the previous lecture. Late complication, very important. First of all, malunion. It is very common due to unreduced or failure of the holding the reduction. Delayed union, also one of the late complications of Colles fracture. Stiffness of the wrist, fingers, elbow, and shoulder due to improper physiotherapy after the POP application. Tendon rupture, mainly the extensor pollicis longus that pass on the radial styloid, so it can be liable for rupture due to the friction. And last complication called carpal tunnel syndrome. Sometimes we face it after Colles fracture. This picture demonstrates the rupture of extensor pollicis longus. The patient cannot do extension of the thumb, and this is one of the late complications of Colles fracture. The other fracture that sometimes we face it in the distal part of radius, it is called a reverse Colles or a Smith fracture. It is the same as Colles fracture, but here the distal segment, in spite of displaced posteriorly, the segments go anteriorly, as you see. Not the ventral or anterior displacement of the distal piece. So the Smith fracture, also named as a reverse Colles fracture. In displaced Smith fracture, the patient presented with deformity called garden spade deformity. As you see in this picture, it is like the garden spade. Treatment of this fracture, like Colles fracture, in displaced fracture, need reduction and put the distal piece in extension position. The forearm also immobilized in bag slab and then change it to POP. But here, very important is to apply the bag slab on the volar aspect. So like anterior slab. This demonstrates the difference between Colles fracture and the Smith fracture. The Smith fracture, the distal piece displaced anteriorly, while in Colles fracture, the distal piece displaced dorsally or posteriorly. And also, this is the difference between the clinical sign, the Dinner-Fogg deformity. It is a clinical sign for Colles fracture, while the garden spade deformity is the clinical sign for displaced Smith fracture or reverse Colles fracture. This is very clear picture for what we call a Smith fracture. As you see, it is a transverse fracture with the displacement of the distal piece anteriorly. Is it clear till now? Anterior aspect. We apply bag slab in a Smith fracture, volary anterior. Anterior side, not on the dorsal side. And wrist in extension position, not deflection. While in Colles fracture, we apply a bag slab, a wrist in 15-degree flexion and 15-degree ulnar deviation of the hand. Is it clear? Okay. The other fracture that can face it in distal radius called a radial styloid process fracture. This injury is caused by forceful radial deviation of the wrist and also called a chauffeur fracture and may occur after a fall. Here the fracture line extended from the articular surface of the radius and go laterally. The treatment of this fracture, it is type of intra-articular fracture. So good or perfect anatomical reduction is very important. If there is displacement, the fracture should be reduced by manipulation under anesthesia. Then bag slab below elbow till the neck of the metacarpal. Imperfect reduction will lead to fracture. So any displaced fracture sometimes mainly need open reduction and fixation by wire or by compression screw. As you see here, the fracture extends from the articular surface and go laterally. It is a chauffeur fracture or radial styloid process fracture, and it is type of intra-articular fracture. So any displaced intra-articular fracture, we must do open reduction and fixation by compression screw, like here in this picture. This is a radial styloid process. Need open reduction and fixation by screw. Barton fracture, it is similar to Colles and Smith fracture, but here the distal part of the radius, the fracture extended to the articular surface. So it is intra-articular fracture of the lower end of radius with subluxation of the wrist joint. It is of two types. First of all, volar Barton fracture, and this is called a true Barton fracture, and it is associated with volar subluxation of the carpus and the hand. The fracture line runs obliquely across the volar lip of the radius into the wrist joint. The distal segment displaced anteriorly and carrying the carpus on it. The treatment of this fracture is very easy to be reduced, but it is unstable and liable for redisplacement. So most of these fractures need open reduction and internal fixation, but by a buttress plate or plate. Dorsal Barton fracture, it is reverse to the volar one. This fracture is very easy to control than volar, and it is usually reduced by close reduction, and the forearm is immobilized in cast for 6 weeks. This picture demonstrates the volar Barton fracture. As you see here, it is not like a Colles fracture. The Colles fracture, it is transverse fracture in the distal piece. But here it is an longitudinal fracture. The fracture extends from the distal part of radius and it extends to the articular surface, as you see here. So this is a volar type of Barton fracture, and usually need a buttress plate for immobilization of this fracture. You catch the difference between Barton fracture and Colles and Smith fracture. طلاب معانا ما معانا؟
يا دكتور معك.
اوكي. الفرق يعني understand it. اوكي. الكوليز فراكتر والبارتون فراكتر والراديال ستايلويد. اذا جينا سؤال enumerate the fracture that could happen in the distal part of radius. So it is Colles fracture, Smith fracture, radial styloid fracture, and Barton fracture. Barton fracture of two types, volar and dorsal. Volar Barton is similar to Smith fracture, and it is unstable, more common than dorsal Barton fracture. So volar Barton fracture needs up reduction and fixation because it is a type of intra-articular fracture, and also it is unstable type. Complication of Barton fracture, complication of radial styloid fracture, complication of a Smith fracture, like Colles fracture. In addition, in Barton and the radial styloid process fracture, the osteoarthritis is common because the fracture of the articular surface as a late complication. Fracture scaphoid, very important to know the details about the fracture scaphoid because it is common. Scaphoid bone accounts 75% of all carpal fractures. They are rare in elderly and children. It is caused by a fall in outstretched hand. The most important point in scaphoid bone is its blood supply, that it enters the bone from the distal to proximal. So the blood comes from the distal segment to the proximal piece. This fact explains why only 1% of the fracture in the distal part of the scaphoid bone, 20% of fracture in the middle part, and 40% of the proximal part will develop avascular necrosis and aneurysm. So this fracture, if happen, and if the fracture is displaced, it is more liable for non-union and avascular necrosis, especially if it is happen in the west of because it will cut the blood supply to the proximal part. This is the shape of the fracture through the west of the scaphoid or through the distal part of the scaphoid bone. As this is the fracture in the distal part, in the west, and the proximal part of the scaphoid bone. The commonest site for the fracture is through the west of the scaphoid bone. Clinically, how the patient presented to us with the scaphoid bone fracture. Usually the patient presented with history of fallen outstretched hand and complain from severe pain and limitation of movement of the wrist joint, with pain and local tenderness at the anatomical snub box. The boundaries of anatomical snub box is by extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus, and the base of this anatomical snub box lie the scaphoid bone. Of the scaphoid bone, very important structure passes through that area called radial artery. In X-ray, AP view, lateral view, oblique view are all essential in diagnosis of scaphoid bone fracture. Sometimes recent fractures show itself only in rotate the hand into ulnar side. It is called scaphoid bone, scaphoid view. So usually we need AP and lateral view. Sometimes need special view called scaphoid view. We mean by scaphoid view, we put the hand on this film and we do ulnar deviation of the hand to take the scaphoid view. Usually the fracture is a transverse and through the narrowest part of the bone, yani through the west, the fracture could happen. But it could be in the proximal pole or in the trabeculae of the scaphoid. Few weeks after the injury, the fracture will be more obvious as we discussed in the rule of two, the 2 times because sometimes the fracture line not so obvious in the early X-ray. And after 2 weeks, the fracture will appear more clear. In old ununited fracture, there will be a sclerosis at the edge of the scaphoid bone fracture, and the appearance will be as there is an extra carpal bone in the wrist joint. Sclerosis of the proximal fragment is pathognomonic of avascular necrosis of the proximal fragment. Treatment for scaphoid bone fracture. Most of the scaphoid fracture in undisplaced type, conservative treatment by a POP full cast in 80–90% of the cases, and the end result with good healing. The cast is applied from the upper forearm to the metacarpophalangeal joint of the finger. But it should be include the proximal phalanx of the thumb. The wrist is held in dorsiflexion and the thumb in forward position, and in this position called a glass holding position. We keep the plaster of Paris or what we call a glass holding position, thumb spica, for about 6 weeks. This is very important to know. This is what we call a thumb spica, or what we call a glass holding position for immobilization of the thumb and the hand in a scaphoid bone fracture. After 6 weeks, we can remove the BOP and re-examine the patient clinically and radiologically. If there is no tenderness and the X-ray shows sign of healing, and that is all. But if there is a local tenderness or there is an X-ray obvious that there is a fracture line appear, so we need another 6 weeks for immobilization of the fracture. For displaced fracture, the treatment by open reduction and a compression screw. There is an indication for open reduction here because the fracture is intra-articular, and this fracture liable for non-union. So in displaced fracture, need open reduction and fixation by a screw. The type of screw called a Herbert screw. It is type of screw is called also, the other name is headless screw. This screw is usually embedded inside the bone, totally embedded inside the bone. And this is the method how we can introduce the screw to the scaphoid bone. As you see here, this is the technique how we can apply the Herbert screw through the scaphoid bone. And this is end result picture. This is the headless screw. As you see, the whole screw is embedded inside the bone. Complication of scaphoid bone. First of all, avascular necrosis. The proximal fragment may die, especially with the proximal pole fracture. It will appear as a dense bone in X-ray. The treatment sometimes needs excision of the proximal fragment. Non-union, that is more common than avascular necrosis. Because the fracture, it is intra-articular, and the special blood supply, these increase the risk for non-union. So after 3 months, if the fracture not unite, it will be obvious that the fracture will not unite at all. The treatment in old people and in those who are completely asymptomatic, non-union may be left untreated. In young patients, treated by open reduction, fixation, and bone graft. As you see here, it is 2 examples for non-union. You can see the sclerotic age, and there is no obvious healing of the fracture. And it appears in X-ray as an extra carpal bone. This picture shows not so clear the avascular necrosis of the proximal part of the scaphoid bone. As you see here, it appears as like a dense bone. Sometimes the graft fails, and sometimes need excision of the scaphoid bone and diffusion of the carpal bone, like arthrodesis of the wrist. The osteoarthritis is the end result of non-union or avascular necrosis. It is type of secondary osteoarthritis of the wrist joint. Okay. Any question, طلاب?
دكتور لما نعمل فيوجن بالكاربال ما راح يصير مثلا deformity أو
The fusion of the carpal bone sometimes is يعني we can solve the problem by fusion of the carpal bone. Deformity مصي نحن to decrease the pain. And sometimes we need a fusion of the joint يعني arthrodesis sometimes of the wrist joint حتى نتغلب على البين اللي ممكن يحدث نتيجة الاوستيوارثرايتس or avascular necrosis. Deformity مصي but there is a limitation of movement of the wrist joint. يعني نحن نلغي حركة الريست joint by fusion. هاي ايمتى نحتاجها بالحالات الصعبة اللي يصير بها complication after failure of bone grafting or after severe osteoarthritis of the wrist joint.
تمام شكرا دكتور.
أهلا وسهلا. يعني what common complication of fracture scaphoid هو non-union. Avascular necrosis is the second important complication. And lastly osteoarthritis. ليش osteoarthritis؟ أنت مثل ما قلت لكم يعني fracture الليت complication of it هو الاوستيوارثرايتس. بأي مكان يصير عندنا intra-articular fracture ممكن يتعرض للاوستيوارثرايتس as a late complication. موضوع يعني نواجهه أوقات هو الكاربال بون dislocation. يعني أوقات الكاربال بون ما تتعرض للكسر يصير بيها dislocation. فإحنا هم نخلي بالنا هذا الموضوع لأن sometimes we face it in our life. We must first of all know the anatomical, normal anatomical relationship between the carpal bone and the distal part of radius and its relationship with the metacarpal. So, in the lateral view, with the wrist in a neutral position, radius, and this is very important, radius bone, lunate, capitate, and the third metacarpal should lie in one line. طلاب انتبهوا إلى هالموضوع. Lateral view very important. حتى نعرف أنه أكو dislocation or subluxation or something wrong in the X-ray. فنحن نجي نركز على ايش؟ على اللاترال فيو. الاي بي فيو اوقات يكون ما كلش واضح والامور تختلف علينا. بس باللاترال فيو تكون more obvious and we can catch the problem. So we concentrate on the radius bone, lunate and capitate with the third metacarpal. These four bones should lie in one line, as you see here. The relationship between the radius, scaphoid, and capitate with the third metacarpal should be in one line. Okay? Sorry. Again, dorsovolar view sometimes give us some clue about the problem, but we must concentrate on what we called Gilola arc. We have a three curves in the wrist joint in AP view. These three curves should be not disturbed. Any disturbance means something wrong. The first arc called the proximal articular surface of the scaphoid, lunate, and the triquetrum. The second arc is the concavity of the scaphoid, lunate, and the triquetrum. And the third arc is the proximal convexity of the capitate and hamate. As you see, these important three regular line, three curved line. This is the first line, the articulation between the radius and the scaphoid lunate bone. And the second line, it is the concavity of the scaphoid and the lunate. And the third line is the convexity of the capitate and hamate. Very clear to distinguish it here. This is the smooth, the first line, and the second line with the third line. So any disturbance is in this line mean something wrong. Now, dislocation around the lunate bone or dislocation of the wrist joint. A fall on the hand forced into dorsiflexion may tear the tough ligament that binds the carpal bone, and it may cause, first of all, perilunate dislocation. Here, the lunate still stay in its place and attached to the radius, and the rest of the carpus with the hand displaced backward. Okay. In perilunate dislocation, the lunate bone stay in its place in relation with the radius, and the rest of the carpal bone with the hand displaced dorsally. So it is called perilunate dislocation. In lunate dislocation, usually the hand snaps back again to its place. And when this happens, it will push forward the lunate from its position. So here, the lunate is displaced anteriorly. The hand returns back to its place and pushing the lunate bone anteriorly, called the lunate dislocation. The third trauma called the trans-scaphoid perilunate dislocation. Sometimes the scaphoid bone remain attached to the radius and to the lunate by the tough ligament, and the fracture happens through the scaphoid bone. So if this happens, it is called a trans-scaphoid perilunate dislocation. It is very similar to the perilunate dislocation. Here, in addition to the lunate bone, part of the scaphoid bone remain attached to the lunate and stay in its place, and the whole of the scaphoid, the part of the scaphoid, the other part of the scaphoid bone, and the other carpal bone with the hand displaced dorsally. But it is very similar to the perilunate, here, trans-scaphoid perilunate dislocation. Clinical feature. Here, the patient presented with history of fallen or stretched hand. The wrist is painful, swollen, and loss of function. If the carpal tunnel is compressed by the lunate bone, so there is a paresthesia in the course of distribution of the median nerve. The patient can lose of the sensation in the tips of the fingers, thumb, index, and middle finger due to compression of the median nerve. If you look to this X-ray, and if you check the Galola line, here this line is disturbed. The three line is not so clear. And in the lateral view, the line between the radius, lunate, capitate, and the third metacarpal is in not one line. It is in two lines. If we draw the line, like here, the line is not in one line. We have two lines. In lunate dislocation, this is very clear X-ray. The hand in relation to the radius in one line, but the lunate bone, it is away from its place. This is very important emergency in orthopedic because it carries a risk of compression of median nerve because of the anterior displacement of the lunate bone. Treatment. Close reduction by strong pull on the dorsiflexion of the hand may reduce the fracture or may reduce the dislocation to its place. In unstable type, need a percutaneous guy wire for immobilization. If we fail by close reduction, so open reduction is indicated. By anterior approach, which has advantage to decompress the carpal tunnel. The other rare injury that could happen in the ligament, it is called apholunate dissociation. Result from injury of the scaphoid lunate ligament, and this is tough ligament that hold the scaphoid to the lunate. But if there is injury to this ligament, there is a radiographic diagnosis by what we call a hematoma sign due to widening of the space between the scaphoid and the lunate more than 2 millimeters. X-ray that is similar to the gap of the comedian called Terry Thomas person has a space between his front teeth. It is most In most cases, this problem is treated as a sprain and no further follow-up is required. So here, this is the gap between the scaphoid and the lunate due to dissociation or destruction of the ligament that hold the scaphoid to the lunate. This picture, it is similar to the defect in this man اللي هو Thomas, and it is called Thomas sign. Any question, Lab? Okay. Metacarpal fracture. It is a small tubular bone. A fracture of the metacarpal shaft results from direct trauma or from a twisting injury. Direct trauma blow may fracture one or several bones of the metacarpal. Twisting force may cause a spiral fracture of the metacarpal. Clinically, the patient, of course, presented with history of trauma, complaining from severe pain, swelling, and deformity of the metacarpal area. The treatment, like for oblique or transverse fracture, with a slight displacement by grape bandage. For a transverse fracture, with displacement may need a slight manipulation. If we fail, we need open reduction and K-wire fixation. For a spiral fracture, may need K-wire or plate and screws fixation. It is like fracture of long bone, but here the fracture of the small tubular bone. We can face a lot of fractures, as I said, transverse, oblique, spiral. Most of these fractures are treated by conservative treatment. In severe displaced fracture need open reduction and fixation. Very important, a fracture called boxer fracture. It is a fracture of the head of the fifth metacarpal. A direct blow may causing a fracture, usually in the neck of the fifth metacarpal. It is called boxer fracture. The fracture line here in the neck of the fifth metacarpal. The patient presented with pain, local swelling, and the flattening of the nickel. X-ray show an impact transverse fracture with volar angulation of the distal fragment. Treatment, flexion deformity about 30 degrees is accepted, and a good outcome can be expected. Hand is splint in position of function for 3 to 6 weeks. This is the position of function. The wrist is straight and flexion 90 degrees of the metacarpophalangeal joint and application of bag slap. In severe displaced fracture, more than 30 degrees for boxer fracture need open reduction and fixation by K-wire. مصطلح آخر يجينا هو Bennett fracture. It is a fracture dislocation. This fracture occurs at the base of the first metacarpal and is commonly due to a punching injury. Fracture usually oblique and may be extended into the carpometacarpal joint. And this type of fracture is unstable type. This injury is typically caused by axial loading on the partially flexed metacarpal. So the thumb look short and carpometacarpal region is swollen. The fracture is usually displaced. The first metacarpal shaft subluxate dorsally and proximally, and also radially, due to the pull of the important muscle called abductor pollicis longus, extensor pollicis longus. Extensor pollicis brevis and abductor pollicis brevis, which is remain attached to the fracture fragment. So we have an axial load by a pulling of extensor pollicis longus and abductor pollicis longus, and also there is other muscle attached to these segment It is called adductor Colles brevis, and other extensor muscle, intrinsic muscle, sorry, can lead to displacement of the fracture. X-ray show the fracture at the base of the metacarpal, and we can diagnose it by X-ray. Here in this fracture, perfect anatomical reduction, it is mandatory because it is also type of intra-articular fracture. Also, there's a lot of muscle and tendons attached to these pieces. So open reduction and internal fixation sometimes is the clue for this fracture. Jersey finger. What we mean by jersey finger? It is rupture of the flexor digitorum profundus from the distal phalanx and may occur within avulsion fracture. Jersey finger can result from the cut of the tendon attached to the distal phalanx or from avulsion fracture of the distal phalanx. But this happens in the flexor tendons, not in extensor. An extensor tendon called mallet, and we'll discuss it later on. And a flexor, if the injury to the flexor tendon at the site of the attachment to the distal phalanx, it is called jersey finger. Sign and symptom: finger cannot be flexed. The finger stuck in extension. The patient presented with history of trauma, complaining of pain and local tenderness over the distal phalanx. The treatment usually by surgery, and we must do surgery within 10 days. After that, it carries a lot of complication and even failure. As you see in this picture, after operation and suturing of the tendon, we apply a splint, and this is a hinge for movement of the finger to prevent stiffness of the finger joint. The other topic called jammed finger. Jammed finger is forced axial loading to the tip of the finger. It is a common in sport injury. Sign and symptoms. The patient usually complains from severe tenderness on the finger and lateral instability with the swelling. X-ray, very important to exclude a fracture that could associated with this injury. Treatment by ice application and splintage. And then we can tap finger to other and return back to play. As you see here, it is an injury to the ligament of the phalanx. We can apply ice and we can tap the finger to other and start movement to prevent stiffness of the finger. Gamekeeper thumb. It is caused by injury to ulnar collateral ligament. And this injury may be strained or completely cut of the lateral collateral ligament. The patient presented with history of trauma, complaining from pain on ulnar collateral side, weakness and pain with pinch, swelling over the medial aspect of the thumb, and also joint instability. The X-ray, very important to exclude the fracture. The treatment, usually by splint for 4 to 6 weeks by cast immobilization. As you see here, there is over movement due to injury of ulnar collateral ligament of the thumb. And usually we treat it by immobilization in cast or by splint. Mallet finger, more common than jersey finger. There are 3 types of mallet finger. First of all, a tendon avulsion, small piece of bone avulsion, and large piece of bone avulsion. This happens after a sudden affliction of the terminal phalanx, and this may lead to cut of the tendon or avulsion of a small piece or big piece from the distal phalanx. The mallet finger, the patient presented of loss of extension of the distal phalanx and incomplete extension of the distal phalanx. Treatment, usually by immobilization of the terminal joint in a slight hyperextension position by special mallet splint. Occasionally, K-wire needed to hold the reduction. Reattachment of the bone fragment. It is difficult and maybe not improve the functional outcome result. So most of the mallet finger are treated by splint, called mallet splint, immobilize the distal phalanx in hyperextension position until the healing of the injury site. It usually takes about 4 to 6 weeks to complete healing. This is old-fashioned for immobilization of the mallet finger by what we call a Zimmer splint. And this is the new model for immobilization of the mallet finger. Complication of mallet finger, non-union. This is usually painless and treated is not essential. Persistent drop, about 85% of the mallet finger recover full extension. If there is a persistent drop in the distal phalanx, this can be treated by tendon repair supported by K-wire, fixation of the joint. But the results are often disappointing and the alternative method for joint arthrodesis sometimes needed. The other complication called the swan neck deformity of the finger. Fracture phalanx also sometimes face it. It results from directed trauma to the phalanx or to the fingers. This will lead to considerable swelling, and sometimes we face a displaced fracture phalanx, spiral fracture, oblique fracture, comminuted fracture. In undisplaced fracture, we can treat them by bracing finger to other and by application of the tape around finger to other and start movement to prevent stiffness. And in displaced fracture, we can use multiple K-wire for holding the fracture, or we can use a screw in a spinal fracture, sometimes a plate and screws. It is a mini plate and screws, like a treatment of all of longitubular bone. Treatment may result in stiffness of the finger, which is sometimes can be worse than no finger. Lastly, we must know the subungual hematoma. Subungual hematoma is the bleeding under the nail. This results from contusion or crushing injury to the phalanx. That is causing a bleeding under the nail. The patient presented with history of a trauma, complaining from severe pain, and also we can face a blood. We can see a blood under the nail and the appearance of a bluish discoloration of the nail. Treatment for this problem is by doing a drilling for the nail by a needle. We can drill the nail and evacuate the hematoma that collected under the nail. Very important is not to drill the nail if there is fracture. When there is a fracture, we not do a drilling of the nail. But if there is no fracture, we can evacuate the hematoma by do simple puncture of the nail. And this is the different type of a fracture in the distal phalanx, usually treated by conservative treatment and immobilization by finger to other with analgesia, and sometimes need antibiotic. And thank you. Now, sorry, تيري ثوماس فرق عن ايش؟ Kind book, yes, about necrosis of the unit bone. تيري ثوماس يعني هسه نرجع للصورة. If you look to this picture, نحن ايش عندنا important 3 lines, the line, تمام؟ When it disturbance, when there is space, relationship between the carpal bone, about 1 to 2 millimeter articulation between the carpal bone and the joint. Here, the distance is very big, more than 5 or 4 millimeters. So there is disturbance in the space due to dissociation of the ligament, due to rupture of the ligament that hold the unit to the scaphoid. سؤالك كان انه عشان نفرق هذه عن الايش الكان بوك ديزيز اللي هو ابر necrosis of the lunate. This is the scaphoid bone, تمام؟ and this is the lunate. You see it? الابر necrosis يعني the density of the lunate bone is increased and the relationship between the scaphoid and the lunate is normal. يعني ماكو space between the scaphoid and the lunate. Just increase the density of the lunate bone. Is it clear? واضحة؟ هذه رير يعني احنا التي ثوماس ساين او راديو سكافويد يونت ديسوشيشن از رير ما دائما نشوفها بس نحن نخليها ببالنا حتى هي واحد من الانجريز اللي ممكن sometimes we face it وعادة تعالج as a sprain يعني not so important. بعض الحالات تنتهي باوستيوارثرايتس. اوكي other question. نحن هذول يدخل مصطلحات طلاب يعني boxer injury what we mean by boxer injury it is a fracture through the neck of the fifth metacarpal. تمام يجيكم بالام سي كيو قد يكون. boxer injury mean avulsion fracture of tendon. It is avulsion fracture at the site of insertion of the tendon or site of origin of the tendon. فإن دفش معنات المصطلحات boxer injury or fracture of the neck of the fifth metacarpal. The Bennett fracture very important because it is intra-articular fracture. It is unstable fracture. When it happened, it is a fracture in the base of first metacarpal. Okay. Jersey finger نحن عندنا قلنا الافالشن fracture at the site of insertion of the flexor اللي هي عكس ليش المالت finger. سؤال طلاب؟